I'd like to say something else. It's nice to talk to an audience with one of the people who held my hands as I started TRAP as the chairperson first session. Thank you, Thomas. Trabeculectomy, I'll actually spend more time about the steps and what happens during the steps rather than the problems that we can encounter at each step. As far as the indication is concerned, it's fairly straightforward and simple for me. Any glaucoma where the target IOP is not reachable medically, according to you. There are situations where we have a time constraint also, where medical therapy is just taking too long for it to get controlled. Like, for example, you have an acute closure of 50, you don't have the time to sit and bring it down over the next 3 months. And then you may opt for a TRAB earlier. And when he got a reasonably controlled intraocular pressure in a patient who is doing all good and he would like to get off medicines, and quite often they have enough of surface problems after 5-6 years of medical treatment, you can combine TRAP with the cataract surgery because anyway he's going under the knife. A real contraindication would be only a bad ocular disease, and here we would prefer tube shunt. I've even had one patient where I got away with Devendra's favorite techniques, GAT. That was a pemphigus patient. This conjunctiva was looking like a skin, and the other eye is already perforated and has become an anticephaloma, and the pressure was not getting controlled, needed a cataract surgery at the same time. So I did the GAT, and of course, it took Minu to look through the cornea to do the cataract surgery, not me. And 3 years down the line, surprisingly, no drugs, 10 pressures. So GAT does work. I'm not, though you would see me in a lot of fora jumping up and catching Devendra's thought, it does work. Okay. As far as pre-op is concerned, stop pilocarpine, prostaglandin, the two irritating medicines that can keep the conjunctiva inflamed. Start acetazolamide. Mannitol can be given if you think the pressure is too high. Pre-op antibiotics, maybe pre-op steroid drops also if it's an inflamed conjunctiva. You need a speculum. Superior rectus bridal suture will be needed. Alternately, one can go for a traction suture. A traction suture is needed because you need exposure. Can be a problem during surgery, especially if one is going for a limbus-based conjunctival flap. I will not be trying TRAP anytime in the near future because I don't dare to under topical. There is this speculum called Ong speculum. A lot of people use. I have no experience where the lower flange is longer, and that apparently brings the globe low enough for us to escape without a traction suture. A paracentesis should always be a first step for any intraocular surgery because it's easy to do when its globe is firm. At the end of surgery, when the globe is soft, is when you'd need it to reform. And the paracentesis can easily be made in a slow, controlled manner, and don't go in all the way at the start itself. You can decompress the globe, and that goes a long way to reduce your peroperative so-called positive pressure problems. I already said this, okay. Peritomy can be limbus-based or fornix-based. Here, fornix-based peritomy, I prefer to cut the conjunctiva separate from the tenons. Tenons is dissected separately. You need a wide area of subtenon dissection. It's okay if you have a bigger peritomy than this at the limbus. It makes it easier, but I don't like to keep on suturing, so I try to get away with a smaller conjunctival incision with a large subtenon dissection. I'll come to why it's so. If it's a limbus-based peritomy, then a limbus-based flap, you should start your conjunctival incision at least 6-7 millimeters away from the limbus, so it's practically at the superior rectus insertion and not 2-3 millimeters away where you land up right on top of your trap flap. Your scar will be there, and that's going to block your outflow. If there's any sort of conjunctival buttonhole, it needs to be repaired because you need a watertight closure at the end of surgery. You can use, I prefer nylon rather than Vicryl because Vicryl sometimes causes a hole in the conjunctiva where it's absorbing. And near the limbus, it can be brought up and sutured onto the limbus. or a fold can be pulled over as a wing over it and sutured. Mitomycin, I use it for all my surgeries, but then a definitive indication would be where you would expect scarring. That's a retrap, NVG, uveitis. Maybe if when you have got a combined surgery with cataract surgery, you got more inflammation coming from inside, but I use it for all my patients. And a more recent concept, it's not really recent because it's been there for about 15, 20 years, is the ring of steel. If you use mitomycin to a small area of exposure, you have all the cells, fibroblasts dying there. At the edge where the cells are partly killed will keep on dying over the next 1 year and releasing products which will cause the normal zone outside to come in and wall it off because of the inflammation that has been caused at that point. So you will land up with limitations of the bleb, and that is a ring of steel concept. So now we go for a wider area usage of mitomycin. If it's over a small area, you would have a ring of steel more often. 0.2 and 0.4 ml both are used, and multiple sponges are put in, and people use it as if, what works in your hand works. So there are people who use it for 1 minute, and there are people who use it for 4 minutes. But the idea is it should be wide area, more posteriorly placed, and sponges so that a large area is exposed. And after whichever exposure time you want, you take it out. Make sure all the sponges you put in are taken out, because now you put it posterior, you may not be seeing it straight off, and irrigate with copious amount of fluid, go under. You're basically stopping the reaction of the mitomycin. You use 1 or 2 syringes at least of the 10 ml ones. That was not third mitomycin sponge coming out, that was a loop starting to reloop. Nowadays I use injection mitomycin. What is described as a posterior injection, but I tend to make a limbal entry and go in backwards, like for an old posterior subtenon injection style. So my bevel actually lands where it should, and 0.1 ml is injected, and this is rolled back with Johnson's bud so that it's spread over a big area. The advantage of injection is we know exactly how much mitomycin we're using. A sponge, it's variable. I also send some saline through it into that subconjunctival space to separate the conjunctiva and the subtenon where the mitomycin, I believe, is sitting before I go further. It is faster, 1. 2, you are using a definite dose of mitomycin. Sponges can be cut to varying sizes, and you actually don't have an idea of what this dose is. And when you go in with the sponge, you invariably get the conjunctival edge as well. And you can stretch it and tear it, the conjunctiva, a little bit with the sponge also. Scleral flap, after cauterization, to get rid of the vessels, you go for a scleral flap. It's a partial thickness scleral flap. 1/3, maybe even half thickness should be okay, not more than that. I use a crescent knife, 4 mm by 4 mm is what I do. But all that matters is the flap area versus the internal ostium. Lateral overlap is what will actually finally matter. Problems that can happen with the scleral flap is, if we make a flap that's too thin, it'll work like a filter paper, like a sieve, and it'll filter through it. And if it looks too transparent, you can, if possible, go for 1 more layer underneath, or preferably go to another site nearby and start all over again. If you got a tear in the flap and it's too close to the area where we would actually take out the internal ostium block, it will leak anyway, and we may need to do a genu flap or a knee flap, Maumini type of repair, or use a patch graft to cover that area and make the block excision smaller, because you expect it to filter more. Okay. Trap block excision, you can use a scissors, sponge, blade. What I prefer what I've been taught, to use an MVR and make a groove, mark out the area of the block, and then make it full thickness, leaving tiny bridges in between which will be taken off at the end. It's very controlled. What matters is the lateral overlap. That is the gap from here to the edge of the flap. If you got a bigger flap, you need a bigger block. If you got a smaller flap, you adjust the blocks so that you have whatever small gap you need. That is what is going to decide the resistance to the flow. Make sure the ostium is full thickness. If you cut too posterior and you get the scleral spur, you get a hyphema more often because your iridectomy is going to go through ciliary body, or major arterial circle, etc. Vascular stuff is sitting there. And you may be creating a cyclodialysis which may add to your IOP problems later on. Too anterior, I mean, well into clear cornea, there is so much overlap, it will work like your SIC's incision. It will not filter enough. So it will be just into the what is the clear cornea as you see it under the scleral flap. Peripheral iridectomy should be basal, so to make it basal, I first cut the base to start with and then do the iridectomy. If it's not basal, with the flow of aqueous, the root of iris will come in and occlude the ostium. Make sure you reform the AC so that you can see that the iridectomy is complete. If you're not careful, of course, you can injure tissues behind lens, ornules, etc. and vitreous loss if there's a subluxate lens sitting right there. Reform the AC and make sure no tissue prolapses out before you close, and that's one step to counter check. And when you close the flap, the idea is to close it with opposing sutures, not tight sutures. Here you are trying to have a leaky wound, so just oppose is what we want, and not tight sutures. I'm running out of time, I think. Okay. Releasable sutures are useful to put in. It works well if it's released within the first 3 weeks, but it still does give you a pressure reduction over time if you release up to about 2 months. This is the technique that I use. One track through the cornea, then one more track across the limbus cornea to the surface of the scleral flap. And then the idea is not to have a loose end here at the cornea. That's why 2 tracks there. Then across the scleral flap, take the edge of your bed, and from the end, 4 throws around the suture tie, pick up the segment in between on top of the scleral flap and pull through tight. No other ties. If you tie anything more, it's not going to release. Make sure that it can release and trim off the end at the cornea. Post-operatively, there's a bridge there that I'm catching right now. You can be pulling it and can release. I'm just checking if the knot can release before I close up. Conjunctival closure is very important because if it is leaking, the gap between the conjunctiva and the sclera will not be maintained and it will just scar down. You need to have fluid in between as it's healing. So conjunctiva has to be watertight, and get rid of the traction suture, close the corners, and what is in between is tacked down with horizontal mattress sutures onto the cornea is what I use. There are many ways of getting a watertight closure. There are continuous sutures that are described like Weiss suture and things like that, but this works well in my hands, so this is what I use. A horizontal mattress at the limbus to make sure it's watertight. And of course, at the end, I always put a drop of atropine because I don't know which patients plan to go in for a malignant glaucoma. This prevents it to a good extent, is what I believe. And antibiotic steroid, now a drop. Earlier it was a subconjunctival injection that I used to give. Thank you.
Thank you, Dr. George, for that lovely talk with all those video demonstrations. Just a quick question regarding indications. Is there any situation you would do a primary trap without failure, without all these indications you mentioned?
Primary trap, only situation that I've done a primary trap without thinking about anything else is an angle closure, acute closure that is not breaking. And the next situation is an NVG where you have somehow managed to get the retina part sorted out, and it's, you know, this is one thing that will not sit with medicines alone. There I would go again for a primary trap or tube, depending on how bad the pressure is to start with and whether a vitrectomy is done, etc.
Just one more question. Do you have late complications with these injection mitomycins? Because the reason for washing out and things like that doesn't apply here anymore. So does late complications?
Believe me, with the ring of steel concept, even with the sponges, with the injections, I still do get ring of steels and avascular blebs, but less often than what I had in 90s. It's less often, but they do happen with both.
I will just add.
Dr. Gauri.
Please.
That was an excellent presentation with demonstration of the steps. One thing that I would like to reiterate for the young people who are starting off doing trabeculectomy is first, place mitomycin C subconjunctivally before entering the eye, because the drug is endotheliotoxic. Okay, so yeah, and if it reaches the anterior chamber, you are going to have endothelial decompensation. So the first step that you are going to do is to do the conjunctival flap, place the mitomycin C, place it posteriorly. Don't place it just at the limbus, at that site where your scleral flap is going to be. Dissect posteriorly and place it posteriorly, a wider area of application. So that is one thing that is very, very important. Meticulous conjunctival suturing. You should have at the end of a surgery, formed AC, firm eye, not soft, patent PI, round pupil, formed bleb, no leak at the conjunctiva. That means that 50% of your job is done. The rest 50% comes later.
I just want to add one thing, sir, talk about that complication of injection MMC. So we have around this 3-year follow-up data, probably is published in IGO soon. So down the line, I'm using injection mitomycin C since 2014. Really, we don't see any complication because of the injection. The almost similar. But only care we have to take care when the people start injecting mitomycin C, probably they are not injecting posteriorly and they are not pushing it more posteriorly. So that's a condition where the people have lot of complication, to whom I think Madam can add, to whom we teach, really they always have complaint, we have the hypertonic, we have complication. Probably the method is not correct. They are not pushing mitomycin posteriorly. That's why its complication is there.